Good morning, and thank you for joining us for this week's uh, PGY2 Pain and Palliative Care webinar series. We're pleased to welcome this morning Hannah Kowalski. She's a PGY2 Pain and Palliative Care Pharmacy resident at University of Florida Hospitals, and she will be speaking with us this morning on postoperative pain management.
So thank you for joining us today. I would like to present on postoperative pain management, as he said. And a little bit about me before I get started is that I am from Pittsburgh, Pennsylvania originally. I went to Duquesne University in Pittsburgh for my PharmD. I did a PGY1 at Allegheny General Hospital in Pittsburgh and then started my PGY2 here in Florida at UF Health Jacksonville. And then some of the things I do when I'm not doing residency things is baking, watching The Office, and going to the beach now that I'm here in Florida. And some of my favorite restaurants are Domu in Jacksonville, Florida for ramen, and Rizzo's in Pittsburgh, PA for homemade Italian. So let's get started. Today I hope to discuss the prevalence of postoperative pain and consequences of undermanagement, outline preoperative assessments and education, outline pharmacological treatment options for acute postoperative pain management, and discuss the pharmacist's role in postoperative pain management. So the importance of managing postoperative pain. Why do we care about postoperative pain so much? Well, evidence suggests that less than half of patients undergoing surgery report adequate postoperative pain relief. Now, with all of the interventions and pharmacotherapy that we have today for postoperative pain relief, we should try to bring this number up to over half instead of under half. So what does unmanaged postoperative pain cause? Chronic pain, prolonged rehabilitation, extended hospital stay, readmissions, and decreased quality of life. What does managed postoperative pain cause? Shorter hospital stays, reduced hospital costs, increased patient satisfaction, improved quality of life, and it may improve clinical outcomes. So all positives when we're managing postoperative pain. So before choosing a regimen, it's important to start with education. Educational element of postoperative pain management consists of educating the patient, family, and caregivers. It's important to educate everyone that's involved in the surgical process so that everyone's on the same page prior to coming in for the actual surgery. The management of postoperative pain guidelines that were created by the American Pain Society and the update of 2016 focuses a lot on educating patients and their family members prior to surgery. We want to individualize the education, make it age appropriate, go for an appropriate literacy level, culturally appropriate, and linguistically appropriate. We need to make sure that the patient's feeling comfortable when being educated, as well as feeling that they're part of the education and not just being lectured. Allow for a discussion. Although providers have limited time with patients, it's important to allow for the discussion and to allow for questions, concerns, and options to be brought up. It's important for the patient to feel as if they're making decisions for themselves because they should be. Patient care is autonomous among the patients, so it's important to recognize that even in surgery. Education may include holding and continuing medications for surgery, tapering plans for medications that cannot be abruptly stopped, how pain will be assessed and reported, individualized perioperative pain management approaches through pharmacological and non-pharmacological approaches, and realistic goals and expectations for pain control. I'd like to highlight these 2 points just because I feel that these are very important to let the patient in on before they come in for surgery. How pain will be assessed is very important to understand, so that when a patient gives a number or looks at a face or however the pain scale that's being used is assessed, they need to know so that they're assessing their pain appropriately and not feeling that they don't understand what numbers or functions they're giving. And then realistic pain goals and expectations of the surgery is important as well, because if a patient knows that they're going to come out of surgery in pain, or maybe post-op day 3 is said to be more painful than post-op day 4, those are kind of things that can be said ahead of time so that if a patient is in pain, they know that it's potentially normal, or we know that maybe it's not normal. So assessing and reassessing is very important. So preoperative assessment may include a physical assessment, a past medical history, medical and psychiatric comorbidities, home medications, past medical histories of pain, substance abuse history, and previous postoperative treatment regimens that may have worked in the past. It's important to get this information from patients so that we know going into it that this may work better than something else because the patient's already tried it. That makes our job a little bit easier, and it shows that we're listening to the patient and what they believe works best for them. Reassessment is important as well because if changes occur prior to surgery, it's important to address those, as well as reassessing the patient for efficacy of the pain management plan. We can plan, but until the surgery actually happens, we may not know if our plan is efficacious. Side effects of or adverse reactions to drugs can change the plan. Monitoring postoperative progress. If a patient is still only maybe walking 1 foot with PT after surgery, and normally patients would be walking down the hallway, that's really important to address. Maybe we're not hitting the right maybe we don't have the right regimen for the patient. Maybe we're not helping them as much as we can. So those are things to assess as well. Is it working through progress? And then 15 to 30 minutes after a parenteral drug dose is given, or 1 to 2 hours after administration of an oral medication, we should be assessing and reassessing for pain, just to know if what we're giving is helping or if we need to make adjustments. Pain assessment tools are different among institutions, and that's basically what the American Pain Society guidelines said for postoperative pain assessments, is that you're to use the pain scale that works best at your institution. They didn't give a concrete recommendation on which pain scale to use, but here they are listed, and I know a lot of people are very familiar with the numeric rating scales. The 11.1 is very common, of 0 to 10. The verbal rating scale and visual analog scale. The visual analog scale I've seen more in studies of pain, and then the pain thermometer is also a visual way for patients to look at their pain, and potentially this could help them rate it easier for them to understand. The FACES rating scale is also an option. And then for patients that are not necessarily verbal and cannot maybe participate in a normal pain scale or a pain scale for someone that is verbal, there are behavioral pain scales. And these assessments can be helpful in intubated patients, complications with ventilators and facial expressions and upper limb movements, to assess those for potentially pain and discomfort. And they actually looked at in the Critical Care Med from guidelines from 2012, it was an article that assessed pain intensity and pain distress for these 2 variables of, and the family was actually able to give a better report of what the patient's pain was compared to physician and nurses. Although the agreement was only rated as moderate, it still tells us that some families can play an important role in helping make their loved ones more comfortable. So non-pharmacological and pharmacological approaches. The American Pain Society recommendation number 6 says to offer multimodal analgesia, or the use of a variety of analgesic medications and techniques combined with non-pharmacological interventions for treatment of postoperative pain in children and adults. This is a strong recommendation and a high-quality evidence recommendation. So for non-pharmacological interventions, we have a TENS unit. I pulled this one out specifically because I thought it was interesting that they made the recommendation to potentially utilize one of these in a patient that's been assessed for appropriateness of a TENS unit, but also safety of one as well. And the TENS units are transcutaneous electrical nerve stimulators that potentially work by activating endogenous descending inhibitory pathways that would activate the opioid receptors to reduce the central excitability and reduce pain through stimulatory effects of the afferent fibers. So basically calming things down by blocking the receptors endogenously, which could be very helpful in reducing the amount of pharmacological agents that we need potentially. So the guidelines didn't give a specific regimen recommendation, but they did highlight the TENS units. And then a study also highlighted the TENS unit by Bordahl and colleagues. They looked at 21 randomized placebo-controlled trials of 1,350 patients, and they found that there was a mean reduction in analgesic consumption of about 26.5%, and it ranged from about -6% to 51% higher. So that's pretty interesting that this TENS unit can help decrease analgesic consumption that much. Acupuncture and massage were also discussed, but there was no recommendation to use or not use. And then we also have interventional options. I just simply listed some options here because, as we know, interventional options is a webinar in itself. So I just wanted to make sure that I did mention that interventional options can be used and be an important part of postoperative pain management if it's safe and appropriate for the patient. So now on to pharmacological interventions. Opioid therapy is a mainstay postoperative therapy. It can enhance the multimodal approach. However, there are some concerns with opioid therapy, such as ileus, respiratory depression, delirium, sedation, lengthen ICU stays, and also worsen postoperative ICU outcomes. And with opioids, however, there are many formulations of them, as we know, so they can be utilized in a very diverse population. I didn't talk much about opioid therapy because I think it's important to recognize the multimodal approach of non-opioid therapy. We hear a lot about opioids, but I would like to discuss more so the non-opioid options that the guidelines highlighted. So non-steroidal anti-inflammatory drugs, or NSAIDs, they work through a variable selectivity or non-selectivity through inhibition of cyclooxygenase COX-1 and COX-2 enzymes. They decrease prostaglandins, which are a key component in the inflammatory response. They work both peripherally at the site of injury, but also centrally via the spinal cord, where prostaglandins are said to interfere with the antinociceptive pathways. So essentially, they're turning off the inflammatory response, hopefully. So with NSAIDs, however, they don't come free of risk. So the choosing an agent is important, and it's chosen based on contraindications, adverse side effects, past successes or failures, and the formulations available to what the patient needs. Contraindications and cautions with NSAIDs include GI bleed, ulcerations, renal dysfunction, cardiovascular history or events, and stroke. These are all things to consider, especially when collecting past medical histories or considering why the patient is getting surgery in the first place. And then for our types of NSAIDs, we have non-selective ibuprofen, diclofenac, ketorolac, and naproxen. And then we have a selective COX-2 inhibitor, celecoxib. So Ekman and colleagues looked at celecoxib specifically in a double-blind placebo-controlled study where patients that were undergoing arthroscopic knee surgery and were diagnosed with knee meniscus disease were getting either placebo or celecoxib 400 milligrams 1 hour prior to procedure. 99 patients received 400 milligrams of celecoxib and 101 patients received placebo. Postoperatively, patients would get celecoxib 200 or placebo at the first request for pain medication. The results showed that there was a decrease in opioid consumption at 10 to 12 hours. That was statistically significant, and then also at 12 to 24 hours. And then decreased opioid consumption at 24 hours was shown to be about 1 tablet between both groups, the celecoxib versus placebo group, respectively. And then opioid analgesics required at 10 to 12 hours. The placebo group had about 41% of patients requiring opioid analgesics, whereas the celecoxib group only required about 22% of their patients required opioid analgesics. And that was also statistically significant. So there is a place for these medications as long as it's evaluated if they're safe and potentially efficacious for the patient. However, looking at the adverse events from the studies, the placebo group had about 37% of, and the celecoxib group had about 18%. So there was actually more adverse events in the placebo group. And then looking at opioid-related events, they specifically looked at central nervous system disorders and constipation. And the placebo group had 12%, where celecoxib group had 3% for CNS disorders. And then constipation, the placebo group had 5% versus the celecoxib group had 1%. But as we just said, there was decreased opioid consumption in the celecoxib group. So we may see decreased opioid-related events because of less use of opioids. So NSAID dosing varies, but these are some recommendations that I found through the guidelines, and Celecox and the PAMI initiative. And the celecoxib was said to do 200 to 400 milligrams, 30 minutes to 1 hour preoperatively, and then 200 milligrams twice daily postoperatively for a max of 400 milligrams per day. Ibuprofen 200 to 400 prior to surgery, and then 400 to 800 every 6 to 8 hours with a max of 3,200 milligrams per day. Ketorolac is 15 to 30 milligrams IV every 6 hours, max 120 milligrams per day with a max duration of 5 days. And then naproxen 250 to 500 milligrams PO every 8 to 12 hours with a max of 1,500 milligrams per day. These doses, as I said, can vary, and based on institution, there's probably a practice that you see more often than potentially what I see. And then acetaminophen is our next medication. The mechanism not fully understood on the analgesic effects for it, but it does come in 3 different formulations that can be helpful for patients, whether it's IV, PO, or rectal. And contraindications and cautions with acetaminophen, it's generally well tolerated. However, hepatotoxicity, liver dysfunction, and IV acetaminophen associated hypotension, especially in the critically ill, is something to look out for. And dosing of acetaminophen can be 500 to 1,000 milligrams every 6 hours scheduled, so at a max of 4,000. Scheduled dosing versus as-needed dosing is something in postoperative pain that can be helpful because scheduling the dose means that the patient is actually going to be getting the medication, whereas an as-needed medication may not be given just because the qualifying parameters are not met. That way we know we're giving a multimodal approach to the patient as long as it's safe for that particular patient. Looking at a study by Catabriga and colleagues, it was a single-center, double-blind, placebo-controlled, randomized trial of 113 patients undergoing cardiac surgery. And these patients were split up, 56 receiving paracetamol or IV acetaminophen, and 57 patients in the placebo group. 1 gram was given in 15 minutes prior to the end of surgery, followed by IV acetaminophen 1 gram Q6 hours for 72 hours, or paracetamol, I'm sorry. And then the results showed a decrease in pain intensity at rest at 12, 18, 24 hours after the end of the operation. And then a decrease in opioid consumption from 48 milligrams versus 97 milligrams of morphine in the acetaminophen group versus the placebo group. So I think that's a really big difference, actually, looking at 50 versus 100 milligrams of morphine. So that's something to consider in patients, whether it be critically ill or like ICU patients or floor patients. And the guidelines explained that conditional recommendations to use acetaminophen was generalizable to all acetaminophen routes of administration. So essentially, if a patient is able to take the PO or utilize the rectal acetaminophen, that may be the more beneficial, especially with pharmacists being price conscious. IV acetaminophen is not exactly cheap. So for our gabapentin and pregabalin approach, the mechanism of action behind these medications is they work through voltage-gated ligand-gated ion channels, and the alpha-2 delta subunit of the voltage-gated calcium channels. So the benefits of these medications they reduce opioid requirements after major and minor surgeries potentially, and then also they potentially lower post-operative pain scores. Medications and cautions with these medications, they can cause need to be renally adjusted, so taking caution in renal dysfunction. So Matthiessen and colleagues looked at 23 trials of 1,529 patients. 12 of the 16 studies showed 24-hour opioid consumption was significantly reduced with gabapentin. 5 abdominal hysterectomy trials showed a reduction in morphine consumption, with the weighted mean being 13 milligrams. Early pain scores at rest being about 11 millimeters on the visual analog scale, reduction. Early pain scale scores during activity, a decrease of 8. And then for spinal surgeries, showed a reduction in morphine consumption of about 31 milligrams. Early pain scores of about 20, decrease on the visual analog scale. Late pain scores were about 12. Oh. And this just goes to show that gabapentin in postoperative pain can be efficacious in not only lowering the consumption of opioids, but also in lowering pain scores. And then Mashrinki and colleagues did a systematic review and meta-analysis on gabapentin and the impact of gabapentin on acute and persistent postoperative pain. And they looked at 55 studies and combined doses and administration regimens. Pregabalin results were pain scores at rest decreased, as well as pain scores during movement decreased, which is very good. And then opioid consumption at 24 hours also decreased by about 10 milligrams morphine equivalent. There was also a decrease in postoperative nausea, vomiting, and pruritus compared to placebo, which also makes sense as well because we're giving less opioid that could potentially add to nausea, vomiting, and pruritus. So thinking about that, but also that's a good outcome for patients. And pregabalin had more occurrences of sedation, dizziness, visual disturbances compared to the placebo, which we mentioned are cautions to look out for and side effects to look out for pregabalin and gabapentin. All doses used were as follows and showed an opioid sparing at 24 hours. So this means that lower doses are efficacious in showing an opioid sparing effect. So starting low is most important in patients, and finding that lowest effective dose is the safest way to manage pain, as we all know. So there was no difference in acute pain between only preoperative dosing and pre-postoperative dosing. So this potentially could mean that patients getting the preoperative dose would be enough versus the postoperative dose. However, looking at chronic pain postoperatively, there might be a different outcome. So dosing for gabapentin and pregabalin. Gabapentin can be given 600 to 1200 in 1 to 2 hours preoperatively and 600 milligrams postoperatively in single or multiple doses. I generally see multiple doses and potentially lower doses depending on the patient and the age and renal function. So all of those things are good to assess prior to giving preoperative pain medication and postoperative pain medication. And then also pregabalin is dosed 100 to 300 milligrams preoperatively, followed by the same dose 12 hours later. Again, though, thinking of the study, the lower dose was just as opioid sparing, so potentially starting lower in these patients is okay. Okay. Now turning to IV lidocaine, or IV ketamine, I'm sorry. It is a component of multimodal analgesia that can block the NMDA receptors. So a different approach to pain management compared to opioids. So when considering a population to use it in, it could be used in patients you want to be opioid sparing in, to avoid opioid side effects in, to help opioid tolerant patients and patients that have difficulty tolerating opioids. Contraindications and cautions are history of psychosis, hallucinations and nightmares, dissociative symptoms, as well as hypertensive patients. Dosing for IV ketamine varies, but the Crit Care Medicine as well as the American Pain Society guidelines both made dosing recommendations, and the preoperative bolus dose is the same amongst both guidelines, and then the American Pain Society addressed intraoperative infusions at 10 microgram per kg per minute, and to assess if postoperative infusions are necessary for the patient or appropriate. And then Critical Care Medicine said the infusion of 1 to 2 microgram per kg per minute. So the lower dose in general for the infusion. So Lakowski and colleagues looked at a randomized double-blind placebo-controlled studies between 1966 and 2010 of ketamine in patients. And the ketamine bolus or infusion looked at 91 comparisons in 70 studies, and 4,700 patients were included, and 2,652 in the ketamine group with 2,049 in the placebo group. significant amount of patients. And then 47 of the studies used a core meta-analysis, where 23 used a corroboration of the results. So overall, the results were a reduction in total opioid consumption and an increase in the time to first analgesic were observed across all studies. So decreasing the amount of opioids through delaying the time till the patient needs one, and then also just in general consumption. And surgery specific, it looked at thoracic, upper abdominal, major orthopedic surgery subgroups. And despite the less opioid consumption, 25 of the 32 treatment groups experienced less pain. So less opioids and less pain seems like a win-win. Then Gulia and colleagues did a single-center, double-blind, randomized controlled trial of 93 patients from post-abdominal surgery patients in the ICU. And this was from a study found in the critical care med guidelines for pain, sedation, and delirium. And the ketamine dose was 0.5 mg per kg IV push, 2 mg per kg per minute infusion at 24 hours, but then also 1 mg per kg per minute at 24 hours. So reducing the dose gradually over time. And they saw a decrease in opioid consumption of about 22 milligram of morphine equivalent. And then there was no difference in patient-reported pain intensity, however, and there was no difference in side effects, which is good. So again, with the opportunity to potentially decrease opioid consumption if the patient fits the safety and appropriateness of ketamine. And then IV lidocaine is our last multimodal approach, and that is through the inhibition of sodium channels in peripheral nociceptors. And it was seen in open and laparoscopic abdominal surgeries without contraindications to using lidocaine. And that was recommended by the American Pain Society guidelines for postoperative pain management. And contraindications and cautions showed dizziness, seizures, bradycardia, cardiovascular events or history, hepatic impairment, and renal dysfunction. So it's important to get a thorough history on the patient, remember to assess why they're getting the surgery in the first place, and remembering that lidocaine can cause toxicities that can be fatal. And the American Pain Society guidelines on management of postoperative pain did put some dosing recommendations out there. However, they did recognize that dosing varies among studies, and an induction dose could be 1.5 milligram per kilogram with an intraoperative infusion of 2 milligram per kilogram per hour. They looked at trials, and the trial doses ranged from bolus of 100 to 150 milligrams or 1.5 to 2 milligram per kilogram, and then infusions of 2 to 3 milligram per kilogram per hour through the end of surgery. And a meta-analysis of randomized controlled trials of 29 studies in 1,754 patients resulted in a reduction of opioid requirements of about, again, 10 milligrams. The time to flatus was reduced by about 8 hours. The time to first feces was reduced to about 10 or 11 hours. There was a reduction in pain at rest, as well as during cough and during movement. And abdominal surgery was strongly associated with the benefit. So 12 studies screened for adverse events of cardiac and neurological events that were comparable, and then 8 studies did report toxic plasma levels. And that's also something that can be done too from monitoring, is to get plasma levels of if you're planning on doing an infusion. Insler and colleagues looked at a single-center, double-blind, randomized controlled trial of 100 cardiac surgery patients requiring a postoperative ICU stay. The lidocaine dosing regimen as follows, with a 30 microgram per kilogram per minute infusion for 48 hours. There was no effect on self-reported pain, postoperative fentanyl or sedation consumption, time to extubation, ICU length of stay, and hospital length of stay. So I think this just goes to show that potentially there could be a benefit in some patient populations, but it really just needs to be assessed if it's safe for the patient and appropriate, and also if the benefit outweighs the risk. Because looking at this trial, it doesn't seem like a benefit would outweigh the risk. So options for multimodal therapy include the following that was from the American Pain Society guideline recommendations, and they put a nice table together about the different types of surgeries that could utilize different types of pharmacological therapies. And I would just like to highlight that in spinal infusions, NSAIDs are not listed, and then also in CABG, NSAIDs are not listed. So it's important to really assess the surgery, assess the patient, and the benefits and the risks of the different multimodal therapies that you're choosing. So what is the pharmacist's role in multimodal therapy approaches to pain management? And I think we can really make an impact here because we're able to do med list reviews on our patients, and we're able to see what could potentially be missing. We're able to recognize side effects of medications to make sure they're being addressed, to make sure that patients haven't had reactions in the past, or to do investigative work to see what they have used in the past and were okay with. We are able to help the team titrate doses as appropriate, because sometimes maybe it seems going up on the opioid seems like the best action when we could be increasing doses of gabapentin or putting on Tylenol as scheduled. And those are just little things that can be looked at and fixed so that we can keep opioid use lower and address pain appropriately. Because in the end, we want the patient to get the most benefit from the therapies that they're getting and not just continuously adding on drugs when we can titrate doses of other ones. And we want to encourage finding the lowest effective dose. So maybe not starting at a really high dose that we would see to be thought of as let's hit the patient hard before they go into surgery. However, a lower dose may be just as effective as a higher dose. So especially if you're going to choose potentially ketorolac, those are medications that starting at the lower dose is appropriate, and not starting at the higher doses. And then assessing and reassessing patients' pain. So looking at changing or adjusting medications based on response to assessment. Again, this goes back to looking at progress. So potentially we increase the patient's opioid, however, now they're not able to participate in physical therapy. So that's not helpful for the patient's recovery. Or if we increase the gabapentin and they become sedated and aren't able to participate in physical therapy. Those are things that we need to address with the team as well as with the patient and find the best way to manage the patient's pain, but also allow them to progress forward in their recovery. So thank you very much for listening to the review of postoperative pain management. And now I can take questions.
You're welcome to either unmute yourself or use the chat feature down at the bottom of your screen.
Good. Well, thank you very much for listening to the webinar.
Thank you for tuning in to this week's PGY2 Pain and Palliative Care webinar. You did a great job, Hannah. We certainly appreciate you sharing your expertise with us. As a reminder, this webinar was recorded and will be available on the members portal of the Society of Palliative Care Pharmacists. Thank you all and have a wonderful weekend.
Thank you.